Now, coming on to the individual airways, like airway breathing and circulation, what we were discussing is the confirmation of ET tube. So let's assume a patient has come and he was in gasping respiration and you have intubated. So the first and foremost is definitely your clinical assessment, whether the composition is correct or not, the tube has passed into the trachea or not. So in that situation, you have a clinical assessment that you directly visualized the ET tube passing beyond the vocal cord, and then you did the 5-point auscultation. So all these part is of clinical assessment. And then you, if you have the end-tidal CO2 monitor, you checked in the CO2 monitoring part. But if you have also have the ultrasound available with you, then you can see and you can just put the probe vertically onto the neck of the patient, and you can see what is shown in the picture. That is, in ultrasound you will get a comet sign or the double track sign. So the first image which you can see is the when the ET tube is in the tracheal lumen. So you will see there is a tract which is there, and that is called as double track sign. But if the tube is in the esophagus, like in that situation, definitely your clinical, when you do the first point which you auscultate is the epigastrium. In that situation only, when you push the air in, you will see the gurgling sound in the stomach. So that definitely is your clinical assessment. But again, if you want to further check, you can do with ultrasound. And then if you see there are double tracks, and that is, first you see a hypoechoic shadow in the trachea, and then next to it, if you see the same kind of shadow is there, so that depicts that the tube was in the esophagus. Now, breathing, that is, again, breathing is a little elaborate, where you would be seeing all the lung parts, both the right and the left side. You will have to compare, and then you will have to do in 12 zones. So generally, when you do a lung ultrasound, you have to compare both sides. That you will have to compare right and the left side, and then you will have to do a 12-point ultrasound. So lung ultrasound is also called a sonostethoscope, where you will be checking for pleuropulmonary changes. Like you'll be seeing the pleura, what features it shows, and then you'll also be seeing is there any pulmonary changes with it. So pleura, when we talk about pleura, how a pleura would look like. So it's a hyperechoic structure. Like in the first, which you can see a white line, that is the pleura. It has been marked as pleura. And then what are the A lines and B lines? And A lines would be the horizontal repetition of pleural lines. So in the second video, which you can see, is where it has been marked as A1, A2, A3. So the A lines are, the first one is the pleural line, and then you get a reverberation artifact, which is called as A lines. And this is the horizontal repetition of pleural line. Now, talking about B lines, so B lines are hyperechoic comet tail artifacts which starts from pleura and fade into the depth of image. So these are the vertical lines. A lines are our horizontal lines, and B lines are our vertical line. So generally, when we check in a lung zone, it has to be the minimum which we need is at least there should be 3 to 4 pleural line should be there. But if there is a lot of pleural line, there is a confluence of coming, then it is called as confluent B lines, and it is represents that there is some pleural pathology is there. Also, there could be a pulmonary edema feature. It shows pulmonary edema feature. So in the first video, if you see, both the parietal and the visceral pleura are sliding over to each other, and the vertical line which you are seeing is that is your B line. In the second one, you can see you can't really determine how many exactly B lines are there. You see a band which is just going right and left. So that is called as confluence, and this is how a confluent B line would look like. Now, the lung sliding sign, definitely when both the pleura, that is the visceral and the parietal pleura, they slide over each other, they give a pleural sliding sign, and it synchronizes with the respiration. So during respiration, the lung, there is a visceral pleura, and then there is a small amount of fluid, and the parietal pleura slides over it. So in normal lung, or in when there is no collection of fluid between visceral or the parietal pleura, there is no pleural effusion, or there is no pneumothorax, you should get a lung sliding sign that the parietal pleura should slide over the visceral pleura. And when you convert it to M mode, you get a seashore sign, that the horizontal lines, and then a granular picture which depicts of the lung parenchyma. So these two are normal for the normal lung. So you need to see whether you are getting lung sliding sign in all the zone of lung when you check, and in M mode you need to have seashore sign. What is abnormal is when you don't get a lung sliding sign. So in pneumothorax, when there is a air collection between a visceral and the parietal pleura, you get a absent lung sliding. And when you convert into M mode, you get a stratosphere sign or the barcode sign. So in the first video, the upper video, what you see is if you see keenly, there is no sliding which is happening. The white line which you can see, there is no sliding of visceral pleura over the parietal pleura. And in the M mode, you're just getting these barcode signs. So this is called as stratosphere sign, and this depicts that there could be a pneumothorax. And the third video is showing lung point sign. So what happens is when there is the pneumothorax is not that big, so what you get is there would be a normal lung, and then adjacent to there would be a pneumothorax, the pocket of air. So at the pocket of air, you will get absence lung sliding, and when the normal lung starts, you will get a lung point. So if you can see, if you see in that third video, there is some artifact, the sliding is happening, and then it's stopping at a point that is called as lung point, and beyond that there is no sliding happening. So that is called as lung point. Now, again, when you define, so what we saw when we did a lung ultrasound, we saw whether there were A line present and there were pleural sliding was present or not, and then we saw how many B lines were present. Now, depending on these B lines, if it's focal, the focal could be present in pneumonia, pneumonitis, pulmonary contusion in post-trauma, and pulmonary infarction. Generalized B line, that is confluence of B lines you'll get when there is a cardiogenic pulmonary edema and there is diffuse parenchymal lung disease. Now, how to differentiate between this pulmonary edema or diffuse parenchymal lung disease, that is in ARDS, because in these two you are definitely getting confluence of B lines. Is the pleural line thickening, if there is any subpleural consolidation, or the air bronchogram. Now, in the first picture, it shows pleural line thickening. So, just a second. Yeah. So the first picture, it shows pleural line thickening. You can see patches here and there of white hyperdense shadows. So generally the pleura is not that dense, and if you get scattered pleura or dense pleura, it can depict lung hemorrhage, or it can depict pleural line thickening. The second which you are seeing, the video which you're seeing is, and the bubble which is going up and down, that shows air bronchogram, that is generally presented pneumonia. And the third is your subpleural consolidation. So if you see this third video where the red arrow is marked, so you see there is a pleural sliding happening. The pleura is sliding over, the viscera and the parietal pleura is sliding over each other. And below that, at that red arrow, there is some, consolidation patches there. Okay. So that is how, when you start doing ultrasound, when you start, apart from your clinical judgment and apart from your stethoscope, when you start putting ultrasound probe onto the patient's chest to see how's the pleura or how's the lung. So you'll be able to see all these features in patients of pneumonia or in chest trauma patients. So definitely, these can be quite distinctive, and you will be able to easily identify these changes. Now, atelectasis, there are two more things to be seen in breathing part. That is the when we are doing a lung ultrasound, that is your atelectasis, and how to determine the pleural effusion. So in atelectasis, what happens is the lung is collapsed. So what you get is a lung pulse sign. So generally what happens is when the heart beats, the beating effect of heart is transferred onto the collapsed lung. So that you can see as a lung pulse sign. And in pleural effusion, in the first picture which you can see is there is a collapsed lung and there is a hypoechoic or the dark color fluid which is there. So so that is pleural effusion. And when you measure it at the maximum area and multiply it by 20, you will get the approximate volume which is there in that side of the lung. So that is how we denote, okay, how much amount of fluid would be there or how much amount of effusion has collected. Now, circulation part. So we completed airway, we completed breathing, where we are seeing the lung zones and the ultrasound, and then coming on to the circulation part. Definitely, whenever you do a lung ultrasound or whenever you are assessing the breathing part, any patient who has come up with shortness of breath, so that they can be the most common two causes. Either it could be from the lung side after taking the history and examination, or it could be from the cardiac side. So any patient who came up with, chest pain, chest heaviness, or patient is complaining of shortness of breath, and how to determine whether this shortness of breath is because of the lungs or this shortness of breath is definitely is because of the heart. So in that situation, what we need to do is definitely our history, clinical examination, and the previous history and whatever previous treatment was going on, that plays a very important role. But definitely to determine in which direction our diagnosis is going and to determine how our treatment would be going, these basic steps are required. So in the circulation part, what we do is we check a global cardiac function assessment. So this is the plaques view. So generally when we check, when we do POCUS, that is the focus cardiac ultrasound, that is also called as 2D echo in general term. So in that situation, we do a parasternal long axis view, we do a SLAX, that is the short axis view, and then we do a 4-chamber view. So generally the EF, that is the ejection fraction or the cardiac function assessment, is done in the plaques view, that is the parasternal long axis view. So if you see this clip, the upper part, the triangular chamber, that is your right ventricle. Okay, the uppermost part. Okay, and then the middle part is your right ventricle, which is opening into the aorta. You can see that aortic wall, and then the lowermost chamber, that is your left atrium. So left atrium opens into the left ventricle, and you can see the mitral wall, and then it is going into the aorta with the aortic wall, and the upper side you can see the right ventricle. So in this, when you do a cross section at the level of mitral wall, and then when you do the measurement, you will be able to calculate the EF. So all the equation and all the formula is already fed into the echo machine or the ultrasound machine which has the echo probe. You just need to measure the dimensions of the wall, and you will be making an approximate assumption of what could be the cardiac function. Now, when you rotate the probe in the same position after getting the plaques to the left shoulder, you get a short axis view where you will be getting the left ventricle and the right ventricle, and in that short axis view you will be able to see whether there is any regional wall motion abnormality or not, to see which portion of left ventricle is not working or is hypokinetic. Now, after seeing that, you do a apical 4-chamber view. Now, the circulation part, also what you need to see is you also need to comment on the right heart failure or the right ventricle. Generally, right heart failure, right the patient goes into cor pulmonale in COPD patients and in your PE patient, that is pulmonary embolism. So what you get, the finding what you get is the right ventricular hypokinesis with paradoxical septal movement, that is also called as McConnell signs. Now, if you see this clip which is showing, the right side is your right ventricle and the left side is your left ventricle. Now, if you see the midline, that is the septum. Generally, in a normal heart, the septum doesn't move and the base of the septum, it doesn't come down. But in right heart failure, generally in cor pulmonale or in your pulmonary embolism, you get a dilatation of right ventricle, you get a septal, paradoxical septal movement, and the base of the heart comes down with each beat. So this is a very classical sign which you get in the right heart failure. Now, DVT and venous thromboembolism. So in DVT, what you check is, that is a deep venous thrombosis. You see the leg veins, mostly saphenous at the ankle level, your popliteal at the knee level, and your femoral vein at the groin level or the inguinal level. Now, what you need to see, what we check is whether is there any thrombus present in the vein and whether the vein is compressible or not. So if a thrombus is present in the vein, it can be seen as this in this hyperdense shadow which is you can see in the lumen. So that is the thrombus which is present in the femoral vein. Now, and when you press the probe down, generally the veins are compressible, and you'll be able to completely compress the vein and see whether the vein walls are touching or not. But when a thrombus is present inside, definitely it's obstructing and the vein won't be compressible. So what you do during the screening and diagnosis of DVT, let's say any patient who came up with, swelling in the lower limbs, and patient is complaining of shortness of breath, or patient is complaining of chest pain. So definitely this patient, what I would need to see is, after doing my ABC of ultrasound, I would also check look for DVT. So lower extremity ultrasound screening for DVT should be done, including the central vessels like your common iliacs and the external iliacs. It should be done independent of oxygenation and the coagulation profile. We need not to wait for the D-dimer or if the patient saturation is maintained. So we should not wait. Okay, so there is possibility of DVT. So let me just wait for the saturation to fall down or the patient clinical condition to deteriorate. This screening can be done in emergency itself, but that is the training should be there for the emergency physician. So we need not need radiologists for these things when we start doing ultrasound, when we start using ultrasound. So these key small feature we can identify and can make a presumptive diagnosis. Okay, the case is going in which direction. Now, E. So, as we know, the ABCDEs in emergency or in ICU, everything is via ABCDE. In trauma also, it's ABCDE. So for ultrasound also, I have kept like ABCDE. Now, for E, what we denote is the effective ventilator management. So what do you mean by this is mechanical ventilation guidance can be taken by ultrasound by having the recruitability assessment, by having PEEP titration, response prediction, how the patient is responding to the ventilator management, and mechanical ventilation complications screening, because the patient can have pneumothorax, patient can have paratrauma, there could be atelectasis, or there could be superinfection. So when you start doing ultrasound, you will be able to identify these features. And let's say a patient we have kept the patient on ventilator and the patient is now in ICU. So during ultrasound only, like using ultrasound only, if there is atelectasis, like there was some bronchus plug happened, and that part of lung is not getting ventilated. So that you can immediately check with the ultrasound when there is there is fall in saturation. You have checked everything. You have increased the FiO2 oxygen. You have increased, the PEEP. You have increased your pressures, but still it's not oxygenating. You have suctioned the ET tube, but still, if the oxygen is not improving, you definitely have to check. Okay, what is going wrong? Did the patient had any pneumothorax, or the patient went into ventilator associated lung injury, or the patient had any barotrauma, or the patient there is a mucus plug or bronchus plug, and the lung is not getting ventilated. So instead of waiting for the X-ray technician to come do the X-ray and then go back and share that data with you on the packs or share the film with you, you can just put the probe on the lung and see what happened. Yeah. Ventilation weaning. In ventilation weaning also, it can be used by seeing the readiness, by seeing the prediction, and to see if we started the patient on weaning from the ventilator, and the patient we are unable to wean, what could be the failure, like the cause diagnosis of the failure of weaning. So that is also, that is, a more going into a deeper aspect of using ultrasound, how to see the ventilatory part of it, like how to assess the response of ventilator on the patient. Now, F is fluid status assessment. That is also very important aspect of it. In that fluid status, what you need to see is we check for the IVC, that is the inferior vena cava, and focus, that is in echo you have already seen. Okay, the contractility is good, and then you check for the IVC, and what you need to see is the collapsibility of the IVC with the respiration, like during inspiration how much is the diameter, and during expiration how much is the diameter. So if you see in the picture, so they are measuring two dimensions. So one, when it's completely distance, the walls are completely apart. Wait, yeah, and the second, the walls are getting approximated. So when you measure this, it should be, if the walls are coming nearer and the diameter is changing more than 50%, then it is called as more than 50% compressible. The IVC is compressible.